Hello, everyone. This is Yonis. I am an emergency medicine doctor. We would like to talk about the commonly used protocols to evaluate patients who present to A&E or accident and emergency department with non-traumatic shock. There are different protocols. We are going to concentrate on the most important ones which are used in A&E or emergency department. So stay with us.
So, before starting our presentation, let's talk about the introduction to the topic. The bedside focused or point of care ultrasound is becoming an established technique within the emergency medicine and critical care to answer time-dependent, focused clinical questions. It has some advantages for the physician over the traditional imaging modalities, particularly in the setting of the acute illness. It is safe, rapid, non-invasive, and comes to the patient's bedside. So bedside sonography is not a complete radiological investigation, but rather an extension of the clinical examination to rule out or rule in the key diagnoses in specific clinical setting. The point of care ultrasound is geared with or to addressing the highly time dependent and focused questions. And in general, most of the focused scans become more obviously positive as the patient becomes increasingly unwell. It is indicated, or these are indicated in cases of non-traumatic and differentiated hypotension or shock. Both protocols we are going to talk about, they examine the chest or abdominal cavities by ultrasound in order to rapidly evaluate for the reversible causes of shock and improve an accurate diagnosis. Each of these protocols combines many of the same core ultrasound elements, differing mainly in the exam sequence. So we have this; they are the same, but they are different in the sequences. Okay. So let's talk first about the rapid ultrasound for shock and hypotension, which is RUSH. So RUSH is a POCUS examination protocol that focuses on assessment of heart and major vessels that is divided into 3 steps: pump, and tank and pipes. In principle, we have a fact that there is the free fluid within the peritoneal cavity will settle into the dependent areas within the peritoneum where the patient is supine, which can be detected via ultrasound imaging. So if we see here, the patient is lying down, so the fluid will come here, the fluid will come here. So these are the dependent area where the fluid is lying down. So when you do an ultrasound scan, you will be expecting fluid, so you will be expecting fluid in these areas. Okay, and it's an easily learned and quickly performed shock ultrasound protocol. The goal is to rapidly identify the causes of shock and begin an early goal-directed therapy. This is not a comprehensive examination, as we said, and it should be done within 2 to 3 minutes. We need to have an idea of what is going on or what's happening with the patient. Okay, and then after that, you will be able to expand the examination if you see something like interesting. It is indicated in a non-traumatic hypotension or shock, either hypovolemic, obstructive, cardiogenic, distributive. These are the indications for this type of protocol. And also we have to keep in our mind that there is no absolute contraindication for this protocol. The most important thing is that you should not delay the resuscitation effort. So it's not like taking huge or long time in order to do these protocols or to examine the patient with the ultrasound. So just get the idea and then start to manage the patient. This is the illustration about the pump, the tank, and the pipe. So in the pump, we are going to see with the question, is the pump working, which is the heart? Is there any problem in the pericardium? Is the left ventricle size or contractility issue, if there is any problem with that one? And relative size of the left ventricle compared to the right ventricle. So these are the steps to answer, or the questions to answer about the pump. So we have different views. We have the parasternal view, sub-exavoids view, and apical view. You can see them here. Also, in the tank. So the question is that, is the tank full? You know what I mean? Is there any leaking, or is there any compromise in the tank? Fullness of the tank, which means that evaluation of the inferior vena cava and the jugular veins for the size and collapse within the inspiration. Leaking of the tank, that there is a blood loss, for example, fluid extravasation, or other pathognomic or pathological, fluid collections. Views of the hepatorenal and splenorenal area, and if there is any problem in the bladder area, and it's for the intraperitoneal collection. Tank compromise assessment of both hemithoraces for pneumothorax, and tank overload, if there is assessment of both hemithoraces for pulmonary edema. So these are talking about the tank. So we can see here, this is the exavosternal view, this is the right upper quadrant, left upper quadrant. This is the other view, which is the suprapubic view, and this is the chest. Okay. Now, with regards to the pipes, so in the pipes we need to have a question about, are the pipes obstructed or blocked? Okay. So we have to do systematic assessment of the major arteries and veins for any abnormalities. Ruptured pipes like the AAA and aortic dissection, and also if there is any clogged pipes like in deep venous thrombosis. Okay, this is the protocol. This is the possible findings in shock. So if there is any cardiogenic shock, what we are going to see, there will be a problem in the left ventricle. If there is any hypovolemic shock, small chamber size. So these are the ideas, or these are what we are going to find if there is any problem in the if there is any shock problem. What are the reasons of that? If there is any cardiogenic shock, if there is any hypovolemic shock, obstructive, or if there is any distributive shock. Always we have to keep in our mind that this is a very nice to remember. It's high MAP. Always when you treat a patient with a hypotension, you have to keep a very high mean arterial pressure. So always remember high MAP. So high MAP, if we are going to go with it, or if we are going to divide it, so it will be, first of all, starting with HR, which is the heart. In the heart, we need to look for the global function, if there is any problem in the right side of the heart, if there is any pericardial effusion or tamponade. Okay, so this is the video for the heart. Very nice global function. You can see both of the ventricles are contracting, and this is normal for the global function. Okay, now always in the global function we look at what we call it E-point septal separation. So if we take in the M mode, if we take the M mode and we take the line that crosses the mitral valve, so what we are going to see, this this wave. This is the wave of mitral valve. This wave has E point and there is A point. So these are 2 points in the mitral valve wave. So if we go to the E point, which is this one, and measure the distance between E point and the septum, so this will give us an idea about the contractility of the heart, or about if there is any heart failure. So looking at the E point, which is E point septal separation by M mode, the bigger EPSS, which is E point septal separation, the less ejection fraction is. So if it is more than 10 millimeters, this means that there is heart failure. If it is less than 7 millimeters, there is no heart failure. Okay, so we have to do it in the long axis of the heart, of the view, and we will look at it in this point. In the right ventricle, if there is any right ventricular strain, okay, we'll go to the 4 chambers. This is the 4 chambers view. You can see this one. This is the 4 chamber apical view. This will give us the what is the contractility. You can see here, this is the right ventricle. You can see the right ventricle is congested compared with the left ventricle. Okay, this is if there is any strain in the right ventricle. So there is a strain in the right ventricle. Okay, now if we go to the other point, which is if there is any pericardial effusion, we are going to use the view of the subexhibosternal view here. So this is the subexhibosternal view, this is the liver, and this is the heart, and this is the pericardium, and this is here the pericardial effusion. You can see that one. In subexhibosternal, you can see that there is contraction of the heart, you can see, and it is flooding inside the pericardial effusion. So tamponade, keep in your mind that tamponade is a pericardial effusion plus right atrial diastolic collapse plus right ventricular systolic collapse plus pulsus paradoxicus and high inferior vena cava pressure. Okay, so this is for the heart. If we go down to the eye, which is the inferior vena cava. In the inferior vena cava, we are going to check 2 things. The first one is the decreased pressure, and the second one is the high pressure of the inferior vena cava. Normally, patients who present with a hypovolemic shock, they will have a low pressure in their inferior vena cava. So there will be contraction of the inferior vena cava more than 50%. So you can see that if you can see here. So this is the inferior vena cava here. This one, you can see the inferior vena cava is collapsing with inspiration. So which means that the patient is so hypovolemic. Okay, and the other way the other condition to check if there is any increased pressure in the inferior vena cava. In this case, we had a patient last time in our hospital, in emergency department. He presented with a shock, and this patient came to ED, and we did a fast scan for him, it's not fast, I mean like a rush scan for him. We found that his inferior vena cava was engorged. So you can see that it is not collapsing. And in spite of giving fluids, his blood pressure was very low. So I had to do an ultrasound scan for, like, we did an echocardiogram for the heart. We found that he got a huge pericardial effusion. Okay, so this is increased pressure in the inferior vena cava. Let's talk about M, which is the Morrison's pouch. Morrison's pouch, fast scan initially, here, fast scan initially made for the evaluation of patients in trauma, but we can use it for non-trauma or shock patients. You're looking for fluids in the peritoneal cavity. So here in this patient, in the right upper quadrant area, this is the liver and kidney, and this is the Morrison pouch, and there is some fluid inside. If you can see that one, so this is the ultrasound. You can see there is a fluid between them, between the kidney and liver, and this is one of the ways to evaluate in Russia as well, to concentrate on when we are looking for the cause of shock. Also, in pelvis, we can see if there is any fluid. Most of the ladies, for example, presenting with a ruptured ectopic pregnancy, you will see some fluid. You can see this is the bladder here, and this is the fluid between the bladder and uterus. You can see that one, and also there is a fluid here. So this is also evaluation in rush. We can use it as a way. Also, we can see the left upper quadrant area. So in left upper quadrant area here, which is here, you can see that one. Here is the kidney, and this is spleen, and you can see there is a fluid here. Okay, so always we check suprasplenic, or we can check also para-aortic gutter and kidney. Hey, can you see that fluid here? Okay, so this is highly interesting in a patient who comes to A&E with shock, for example. So this is these are one of the stuff that we are talking about with regards to M. If we get to A, which is the triple A, an aorta, always keep in your mind that triple A means 3 A's. So which means that the upper limit for the aorta, for the abdominal aorta, is 3 centimeters. So if it is more than 3, which means that it is aortic aneurysm. So if looking at this image, you can see that this is the aorta, this is the outer wall of aorta, and this is the inner wall, and here this is the aneurysm. This is the aneurysm. There is a leakage. You can see that one, and this is the color Doppler of it. Okay, so this is abdominal aorta. So you can, once you put the ultrasound scan, you will be able to grab if there is any abdominal aortic aneurysm or not. Okay, so let's talk also about the P, which is the pulmonary area. What are we looking for? We are looking for if there is any pneumothorax or if there is any pleural effusion. So in pneumothorax, normally this is a normal ultrasound. You can see that in this ultrasound there is a sliding of the pleura. This is normal, and this is the chest wall. Here, this is a normal ultrasound for a chest. So when you put the probe by using the linear transducer, okay, this is another image that shows pneumothorax. You can see how this is the pleura. This is the pleura which is not sliding. Okay, so the normal pleura is sliding, and this one is not sliding. So this is the ultrasound of the chest. And also we are going to look at the pleural effusion. You can see that one once we finish this video. Here is the pleural effusion. So in the pleural effusion, it is similar to the fast scan, but we will search in the area which is above the diaphragm. So if we push our probe a little bit up, we will be able to see if this is the pleural effusion, and this is the lung, and this is the liver here. Okay. All right. Okay, so high map version of the Rush examination. These are if there are any in the heart, if there is any pericardial effusion. What is the global ventricular function? What is if there is any RV strain? If there is any abnormality in the left ventricle. Also IVC, if there is any collapse, or if it is collapse or full. Morrison pouch, as we said, right upper quadrant area. And if there is any pleural effusion in the hemoperitoneum. Aorta, okay, is there any aortic aneurysm? Pulmonary area, is there any pneumothorax? Also here, these are the places where we put the ultrasound props in order to ultrasound prop in order to reach the final diagnosis and manage the patient. All right. There is another protocol, we call it the Abdominal and Cardiac Evaluation with Sonography in Shock, ACES. This protocol has been mentioned by the Royal College of Emergency Medicine as well. It provides a rapid focused ultrasound protocol consisting of 6 views for the use in an undifferentiated shock. Many emergency physicians are already familiar with the views from the FAST, which is the Focused Assessment with Sonography in Trauma protocol, and also from the emergency department ultrasound assessment of the abdominal aorta. We have to find out what are the views. As I said, it consists of 6 views, 1 or more cardiac views, inferior vena cava, screen of the abdominal aorta, right and left flank views. So it's pretty similar to the Rush ultrasound or Rush protocol, and the pelvic view. So in certain clinical conditions, additional views may be advantageous, as we said, like if we check for the popliteal vein or for the femoral vein. These are advantages to find out if there is any adding views. Here are the areas how to do the views and where we are going to put the props. Okay. A dilated non-collapsing inferior vena cava. Just to this is the what are the category of shock that are answered by this ACES. If there is any septic shock, what we are going to find in septic shock, we will see hyperdynamic left ventricle, narrow inferior vena cava, there will be normal aorta, and if there is any gynecological or surgical sepsis, or there's pneumonia. And the same, we can talk about the cardiogenic or hypovolemic, obstructive or cardiac tamponade, or obstructive, which is related to pulmonary embolus. So these are the findings in shock that we can diagnose them by using the ACES, or the abdominal and cardiac evaluation with sonography in shock. Okay. The last thing to do is that a dilated, keep it in your mind that dilated non-collapsing inferior vena cava implies that the patient is well filled or overfilled, or that there is an increase in, or there is an obstructive etiology, whereas a narrow fully collapsing inferior vena cava suggests an underfilled patient. Right ventricle is normally 60% of the left ventricle. Okay, so we have to keep this in your mind. So if there is any increase in the right ventricle, it will be noticeable. So we will be able to find out by using the probe. So we'll be able to find out if the right ventricle is enlarged or what we call it hyper. There is enlargement in the right ventricle as a result of any obstructive shock. Focused use of echo can be widely used in an emergency department. This is really important. So we have to make sure that echo is in the position that our colleagues or physicians are completely trained to do echo, because it is highly informative when you are able to do it in the proper way in order to reach the final diagnosis. Here is a very nice illustration. You can see that in the heart, if you evaluate the heart, what we are going to see if there is any fluid, if there is any strain of the right ventricle, or if there is any left ventricular dysfunction. Okay, inferior vena cava as well, and also in Morrison pouch, we are going to see if there is any. This is the inferior vena cava. If it is plethoric or collapsing inferior vena cava. So these are the way. So for example, heart. Check the heart. Is there any fluid around the heart? So it means that the patient has cardiac tamponade. Okay. If there is any increase in the strain, right cardiac strain, which means that there is an obstructive shock. Okay. Also here from this one, if there is any left ventricular dysfunction, we have to check the inferior vena cava, and if there is any plethoric inferior vena cava, which means that there is cardiogenic shock. Okay. This is a very nice chart to show what we are going to do if there is any shock, and how are we going to check the patient or to evaluate the shock in that patient. Okay, these are the references, and I will be more than happy if there is any question after the presentation. Thank you. So these are the two main protocols that we normally use to evaluate patients who present to emergency department with non-traumatic shock. By understanding the physics and the procedure, how to do or to perform the ultrasound, you will be able to find out what is the reason of that shock, and you will be able to manage those patients properly. I hope I covered those protocols in a nice way, smooth way, or simple way. And always, please do not forget to clean the ultrasound machine, because it will be used for another patient. Thank you so much.